Well, good morning and welcome to episode 2, season 1 of WInnovations. I'm your host, Kyle Richards, and we really have a great session planned for this morning, one that's really near and dear to my heart, as we'll be talking about bladder cancer and cystectomy, which is one of my passions. Now, the purpose of these webinars is to highlight some of the exciting and innovative work being done here in the University of Wisconsin Department of Urology. We also want to generate some broader discussion within the urology community so that we can continue to work together with our patients, referring providers, and urologists around the country, researchers, to help make innovative advancements in urologic care. Just for some ground rules now, the format for today's session, we're going to have about a 20-minute presentation broken up into two parts. We'll have about 10 minutes for question and answers. We're going to stop kind of midway through to discuss a few things and break the talk up a little bit. Feel free to answer any questions or comments in the chat at any time during the presentation that you might have those. I'll be monitoring the chat. And our next webinar, we've got a slide pulled up here, will be October 18th from 7:15 to 7:45, hopefully before you start your workday. We'll be featuring Dr. Vinaya Bhatia, who's a pediatric urologist in our department, speaking on pushing the envelope in surgical education, producing high-fidelity models for simulation. So for those of you interested in what's on the docket for education, this will be a really apropos. Now, I'd like to turn things over to Dr. Tudor Borza, our featured speaker. Dr. Borza joined our department in 2018 after completing his fellowship training at the University of Michigan in urologic oncology. In addition to his oncology practice, he's a funded health services researcher and is really passionate about today's topic, which I'm really excited to learn more about, which is leveraging novel technology to improve patient outcomes after cystectomy. And thanks again, Dr. Borza, and the floor is yours.
Well, thank you, Dr. Richards. It's great to be part of the WInnovations seminar series. And as you mentioned, I'll be talking about a lot of work that we've been doing to try to improve how we care for patients after cystectomy, and really focus today on some of the things we've done with our technological advances. So I have some disclosures. They're mostly grant funding, including a grant from the University of Michigan Cancer Center that supported some patient interviews that we've done, and I'll be talking about as part of today's talk. So we all know that radical cystectomy remains the preferred treatment for patients with muscle-invasive bladder cancer. But unfortunately, this is a very morbid procedure. About 70% of patients will experience a complication after surgery. 1 in 5 patients will have a major complication. So this is a Clavian 3 or higher complication. And 1 in 4 patients will require hospital readmission. And these readmissions are a big deal. Most of the time, when patients have a complication, they're going to require at least repeat imaging. Many patients will require an additional procedure, like placement of a surgical drain or nephrostomy tubes. Many patients end up having to go to the ICU, and overall, this leads to an admission that is on par with what the initial surgical hospitalization was. So this entire pattern is extremely disruptive for our patients, the recovery process, and it's very costly for the healthcare system. As a result, many in our field have tried to identify ways to decrease the burden of this procedure. For the last 7 years, I've been part of a multi-institutional, cross-disciplinary working group focused on understanding and improving complications following radical cystectomy. I now co-lead this group, which we've called our CLEAR Working Group, with Dr. Bruce Jacobs from the University of Pittsburgh. And we continue our work to find ways to improve the burden of cystectomy on our patients. A large part of the difficulty with improving these complications is that they can arise from many different factors along the care continuum. There can be patient factors like advanced age and comorbidity, disease aggressiveness and the need for neoadjuvant treatments, and the surgeon's experience. The approach to surgery, whether it's done robotically or open, and the skill of the larger care team can impact the outcome. And so can what happens once the patient leaves the hospital. So we've looked at many of these factors to try to understand and to better understand what is modifiable and how we can improve it. Our working group has been among the leaders in the field, looking at the reasons and timing of the readmissions, the complexity of the readmission episode. We've tried to understand what happens from the time the patient leaves the hospital to when they have to come back for their readmission. And we're not alone here. Many other excellent urologists in our field have looked at understanding what the hospital quality and volume has to do with these complications, how they can modify patient factors, and how we can leverage new ways to manage patients around the time of surgery with enhanced recovery pathways. And despite all of this work from so many smart individuals, there's been no change in complications for over the past 20 years. So if all our work tells us that most complications are largely unavoidable because of the inherent complexity that arises from this interplay between the disease, the patient, and the surgical factors, then what can we do to help these patients? Well, we've come up with two targets to answer this question. The first is to minimize what we've called readmission intensity. This is a concept we've created that accounts for the complexity, duration, and cost of the readmission. The idea here is that we can decrease the burden of complications on both patients and the medical system if we can identify them earlier in less severe forms and then manage them in a lower acuity setting. The second area to target is the patient experience. If patients are going to have these complications, can we better understand what matters most to them in this setting? To answer that question, we actually interviewed patients that were readmitted alongside their caregivers so that we can incorporate their experiences into our new intervention. And now that we've identified those targets, we worked on figuring out novel ways to deliver the intervention. And we came across this, the emergence of remote patient monitoring technology and felt that this really offered a promising path. This technology leverages electronic tracking of patients through messaging apps, vital sign monitoring, and direct patient inputs to improve post-discharge care. We know from medical conditions like patients with congestive heart failure that remote monitoring can improve outcomes and reduce readmission rates once patients are discharged. So far, the data on the benefit of this technology in surgical patients is fairly limited. And a big barrier that's been reported in the literature is the ability to incorporate all of those apps and information into routine clinical care so that we can make it actionable. And at this point, I'll pause for some questions to see if there's anything that's come up.
Yeah, thanks, Dr. Borza. For those of you listening in live, if you have anything to add to the chat, we're monitoring that. Nothing's popping up yet, but I do have a few discussion points that maybe we could go into some more detail, Dr. Borza. When you mentioned interventions to reduce complications, and really nothing has worked. And what are some of the interventions that people have tried? If you could just go through some of the more common ones that people have used, I think that might be useful to sort of help lay the foundation.
Yeah, I mean the field's done a lot here. We've tried to figure out which patients are the best patients to operate. So we've tried to look at all the different factors in a patient's history that could try to give us a sense of whether a patient's at risk for having a complication or not having a complication. And so that's sort of both at the patient level and the big data level to say, is there something in a patient's history that can predict a poor outcome? And we haven't been able to find that. we've done things like trying to make patients better candidates for the surgery. So this is a concept that's been termed prehab. So trying to optimize patients before surgery through physical activity and nutritional support. And that there's maybe a little tiny bit of a signal there, but really nothing that has changed the outcomes in a significant way. We've also looked at trying to improve the setting where the surgery happens. You know, can these surgeries all be done at places that are centers of excellence? If we do the surgeries at a hospital that does so many more of these, that has a team that's trained, are the outcomes going to be substantially better? And on that front, they are somewhat better, but not enough where you can say that this makes all the difference. We've also looked at the approach to surgery. There's a lot of interest in understanding whether a robotic approach can minimize these complications. It's less invasive. We know that in other surgeries we do, the recovery is certainly faster and easier. The same hasn't panned out in the cystectomy populations. The robotic approach appears to be safe, but it's not any safer than the open approach, and the rates of complications are about the same. And then we've looked at policies to try to incentivize hospital systems to better care for patients once they leave the hospital. This is sort of big policy level, through CMS or other state initiatives. And again, none of these have really changed the experience of the patients that undergo cystectomy.
Yeah, that's really fascinating and well said. I think, there is a little bit of a signal, like you said, where it comes to sort of regionalization of these bigger cases to higher volume centers. But you're right. I mean, unfortunately, the needle hasn't been moved a whole lot, despite lots of people really looking at this. Now, when you talk about readmission intensity, that may not be a word that's maybe familiar to a lot of the viewers. Can you just maybe define that or a little bit more, or talk a little bit how you came up with that terminology and what that exactly means?
Yeah, absolutely. That's a great question. So this is an important concept that we've realized in talking about readmissions, and especially in terms of the policy work we've done, is to sort of say that not all readmissions are the same. And if you look at it in the binary, is a patient readmitted or not, that tells a certain story. But for our cystectomy patients, there's much more complexity to that concept. So there's a big difference between a patient being readmitted for a day and getting just some IV hydration and then being discharged home. That is what would be a very low intensity readmission. There's not much cost to it. There's not much disruption to the patient and to the recovery process. Unfortunately, those readmissions are not very common in the cystectomy world. What's more common are these intense readmission episodes where a patient comes in very sick. Immediately they get scanned in the emergency room. They have an emergency room visit. They get scanned. There's a cost there. They may have to be admitted to an ICU or a step-down unit because their vital signs are such that they're not stable for the floor. They get often found to have intra-abdominal infections or obstructions of the urinary system that require interventions. They may not be eating, requiring parenteral nutrition, and then that entire process ends up in an admission that is 5, 6, 7 days or longer. That is a much higher intensity readmission. So this combination of the duration, the things that had to happen during the readmission to get the patient back on the right track, and a measure of cost is what we've put together into this concept of readmission intensity. So we're using one construct to really tell that broader story. So instead of just looking at a yes, no for the readmission, is yes, but what does yes look like? And is it a big deal or not a big deal to help us say that maybe if we can't change how many patients come to the hospital, can we change how sick they are when they get here so that we get them back out of the hospital faster in a less disruptive way and get it done in a way that costs less money? Or perhaps we can even do this in the clinic with certain interventions if we identify patients early enough.
Great. All right. Well, let's keep moving then, Dr. Borza. Thanks for pausing for a little discussion, but let's proceed.
Great. So when talking about these remote symptom monitoring, that I said may be a path forward for improving the care of these cystectomy patients, when creating these tools, the important thing is that they capture the right data at the right time and provide it to the clinical team in an actionable fashion. So, what does that mean for cystectomy patients? Well, we got to figure out which symptoms are the most concerning following the discharge. What's the best way to monitor those symptoms? How frequently should we do it? And how can we integrate this information into clinical care? So to answer these questions, we've really leveraged our clear working group expertise and our prior years of research here. And after carefully considering all of those aspects, we created a mobile health tool to track patients for the first 6 weeks following hospital discharge. So initially, this tool will send push notifications, so kind of like getting a text message, 3 times per day, and then at a decreasing frequency once we get further out from the discharge date. The tool monitors for concerning symptoms like fevers, vomiting, or wound infections. It tracks activity, pain and medication use, and gauges for dehydration by capturing weight, fluid, and nutritional intake. And these are some of the most common things that bring patients back to the hospital. So we wanted to provide, make sure that that's what we were measuring, and the tool certainly does that. Importantly, the tool also provides a direct channel for communication for the patients and the surgical team. And this is something we learned was of highest importance from our patient interviews. We heard frequent descriptions of patients trying to call their surgeon's office. They're having difficulty reaching the correct triage person, often getting bounced around from person to person within a department. And then dealing with long waits before hearing back from their surgical team. Their surgeon might be in the operating room, they may be in clinic and not seeing messages immediately. And all of these create delays. And these delays lead to these long waits. And once the patient is appropriately triaged by the medical team, often they're having to seek care in the emergency room because the process took so long that they're no longer able to be seen in the clinic. The clinic is closed, and now they have to spend the night in the emergency room, either for an admission that would be necessary or just to be evaluated. And that is an extreme source of frustration for our patients. So we really focused on creating a tool that could address that frustration and take away some of those barriers in that clinical care. And lastly, we wanted a tool that was a resource for patients to easily access educational material. I'll talk a little bit more about that in a second. And we wanted a tool that could measure global functional recovery. This is a sort of broader concept of incorporating patient-reported outcomes to really understand what the convalescence of these patients looks like from their own perspective. So one of the things that's most exciting about what we've been able to develop is that we've been able to integrate our tool directly within Epic. And again, Epic is one of the most commonly utilized electronic medical records. And so this allows our patient data, anything that's generated within the tool, to be integrated within a patient's own chart. And it really facilitates alerts to the medical team. So essentially here, a concerning entry using our tool is akin to a patient phone call, but it's done in a streamlined, expedited fashion. This alert is immediately apparent to the appropriate triage team, And it actually shows up in a different in-basket folder than other patient phone calls would. So it immediately triggers that triage person to know that this is a cystectomy patient and they're having a complication or potentially having a complication. So it allows for rapid action with a substantial decrease in that human resource needed for the triage. The alert goes to the exact person that it needs to without having to bounce around multiple phone triage personnel. And also, by creating this app that's aligned with Epic, we are able to create a tool that is easily scalable. So patients across the country at many institutions that use Epic, which is about 80% of patients in the US are covered within an Epic system. So this allows us to really scale our app up with minimal tailoring at each of these hospitals and gives us the ability to help so many more patients this way. So patients will access this tool from their existing MyChart accounts in the same way that they would look up lab results or future appointments. This is something that's very familiar to them, which we hope makes it easier for them to interact with it. The tool works best on a mobile device, but it can be used on a desktop as well. Once the patient is logged on, they can access their assignments and their assigned tasks directly from their homepage. So it's right there. It's always going to be on the homepage. It's very easy for them to go directly to our tool without having to click through many of the other menus. We start engaging patients before the surgery. We do this so we can provide some of those educational resources, which I think really are important to the patients. It allows us to measure those baseline patient-reported outcomes, and really it gives us an opportunity to see if patients are having technical issues. So by engaging them early, if they're having trouble using, downloading the application, downloading MyChart to their smartphone, we have them in the hospital for the better part of a week. So we can really work with them at that time and make sure everything is set up so that they can appropriately receive push notifications once they leave the hospital. At the time of discharge, the tool is reactivated and push notifications resume. I wanted to just highlight one example of what this can look like. So this is the example of our medication and pain assessment. When a patient logs on, they select the types of medications that they've taken. And so this gives us an idea as the medical team how much patients are requiring and will ultimately allow us to sort of better tailor how we care for them. And then patients enter their current pain levels. Depending on those responses, the tool itself actually gives instruction to the patient. So we've taken that out of the hands of a provider and we've programmed that within our tool. So depending on the pain level, it provides advice as to the type of medication that a patient should take at that point. And then additionally, if a patient reports significant pain, an in-basket message is automatically created that gets sent to the medical team. And then the patients are actually given the opportunity to directly contact the medical team. So they're instructed to do so. And then within the application, they're able to click on a phone number that directly calls the clinic or can page a resident if it's after hours. So again, we're really working on streamlining that communication between patients and their providers. We also wanted to create an educational repository for patients. Patients told us in those interviews that they frequently felt overwhelmed by the volume of information presented at their surgical appointments or within the discharge instructions. By placing that same education within this tool, we give patients the ability to explore this information at their own pace and in a far less stressful environment. And the goal here being of increasing that retention of that education and improving the understanding and comfort patients feel. So what patients think of this? Well, the early results are very encouraging. We're currently conducting a single surgeon pilot study. Really, the purpose of this is just to determine acceptability and feasibility. To date, every patient we've approached has elected to participate in this study. This level of patient enthusiasm really speaks to the clear need for a tool like this in the space of cystectomy. I'll tell you, we had concerns that a mobile health intervention might not necessarily appeal to the cystectomy population. Again, older cancer population might not like the idea of a mobile app, but that was not the case. 100% acceptance rate really tells us that we're on the right path here. In terms of engagement with the tool, this has been binary. So the patients who engage, who can get it on their phones and engage, surprisingly completed the majority of tasks for the entire 6 weeks. And this is really a novel finding for a mobile health app like this. But for other patients, problems accessing MyChart really leads to near zero engagement. So there's a clear opportunity for us to improve how we prepare our patients for using the tool. In terms of our early outcomes, we haven't actually had any readmissions. And again, we don't have that many patients, so it's not surprising. And I think this is just coincidence. But we'll see if there's an improvement there once more of our data comes in. The big thing that I'm excited about is that the clinic staff have been so receptive. They know that these patients are really high risk, and they really value having these messages show up in a different folder that can easily alert them, instead of having to sift through 100 phone messages that they may be walking to in their inbox that day. And from the limited experience so far, and our interviews with the nurses, so far they don't feel it's created additional work. They think the work that comes from the app would have come from a phone call anyway. But we'll be looking at this empirically to really try to understand it. And there's, we're doing single surgeon intervention. The rest of the surgeons really are excited, and there's a lot of interest in getting their patients involved as well. So what are our next steps? Well, now that we're actively enrolling patients, we really are starting to analyze the large volume of data that comes in. Every click is a data point that we have access to. And our engineering collaborators are really excited to sort of use these, their machine learning algorithms to try to understand how we can predict, how we can better predict adverse outcomes that might come up, or how we can improve engagement with the data that's generated within the app. And we'll also really focus on stakeholder engagement, trying to gain an in-depth understanding, from the patient and the provider perspective, to try to improve this and make it as streamlined as possible. And once the pilot's complete, we'll work on making the tool accessible to more patients, with the planned expansion at 4 hospitals here at the University of Wisconsin, University of Pittsburgh, the University of North Carolina, and a broader pilot at the University of Michigan. And I'll end by saying that, for trainees out there who might be seeing this, we always welcome your involvement. So whether it's as a research student, as part of your residency, or as part of our Urologic Oncology Fellowship, I think it'd be a great opportunity for all our trainees to be involved in this work. And I'll end there, Dr. Richards, and open it up to see if there's any other questions.
Yeah, thanks, Dr. Borza. Really excellent and exciting work, and we'll be curious to see where this heads in the years to come. I don't see anything popping up in the chat. We're running a little bit short on time, but let me just throw out one other concept maybe you could address in a minute or so. Is now, one of the thoughts that I had is, as you increase MyChart responses, you decrease phone calls, increase MyChart, then the nurses, the clinical staff might have sort of an overwhelming amount of MyChart messages. So at the end, you were talking about getting the nurses and the clinical staff sort of more engaged. Was that part of the process throughout, or is that something you're kind of working on more at the back end here?
Oh no, it came from the beginning. So the clinic and nursing staff are actually involved from the very start, because they're a big part of how this app sort of makes it possible to provide care. That's one of the things that makes it unique, is that it's integrated into the usual care system from the beginning. So we work with the clinics to identify the appropriate personnel, create the appropriate pathways for those messages to show up. And so clinic staff, nursing staff, and triage staff are actually involved from the very beginning. So their input is used to sort of make all our processes, establish all our processes in the first place. And that's why we sort of have that data, and that we're constantly, there's this constant feedback loop that exists. But then at the end of the pilot, we'll actually, measure this empirically to get a sense of how many messages did this generate? How does that compare to usual care? And, what are the perceptions of the clinic staff about those messages? Because if more messages means just better way of caring for the patients and decreasing the workload, that may be a good thing, even though there's a greater number of messages. And so they've been involved throughout, but we'll empirically measure that on the back end as well.
That's great. Yeah, that's what I assumed, but just wanted to make sure that was on the record. So thanks, Dr. Borza, again for a fantastic discussion. And just wanted to highlight our next speaker, Dr. Bhatia, will be presenting October 18th. I hope you all can join us. I want to thank our sponsors, Dr. Nakata, as well as the Department of Urology at UW Health. And I hope you all have a good rest of your days. Take care.